So Acalabrutinib was the first second-generation BTK inhibitor to be approved. As you can see from this study, very early on, it was very low toxicity compared to what we saw with ibrutinib. And the overall response rate and the complete response rate appears to be higher. But again, remember what I said about the pictures. These pictures used for this one are much more sensitive. We typically get much higher response rates with the pictures used for this drug versus what was used for ibrutinib. So the key thing to think about in the initial study, we did not see any atrial fibrillation. The most common side effects were headaches and diarrhea, both of which were very self-limiting, meaning they went away on their own. Very few patients had dose reductions. Very few patients had bleeding events, which is something we also see with ibrutinib. So again, it appears that everything was better with acalabrutinib. But with more time, we have seen that there are cardiac events that are starting to occur with acalabrutinib. So we do see a lot of the very similar toxicities that we see with ibrutinib are starting to come up with acalabrutinib with more time and more patients being treated. So it does beg the question of whether this is a class effect with BTK inhibitors and not just specifically something associated with ibrutinib. Now, the third covalent BTK inhibitor that we have is called Zanubrutinib. This has also been shown in relapsed refractory mantle cell lymphoma to have a very high overall response rate and complete remission rate. Very similar to acalabrutinib, but it was also evaluated with a very sensitive scan compared to ibrutinib. So overall, we think that these drugs are all very similar as far as efficacy. There is really no difference. The differences we see is sort of how the drugs are given. Ibrutinib, as of right now, is one pill that you would take daily. Acalabrutinib is a pill twice a day that you have to take. And Zanubrutinib are 4 pills that you would either take. Either 2 pills you would take twice a day or 4 pills you take once a day as far as management and treatment of your mantle cell lymphoma. So there's a lot of variation of the 3. Obviously, if we have to make dose reductions, it's a little bit easier with ibrutinib or Zanubrutinib. As with acalabrutinib, we'd have to just take away 1 complete pill. So again, all 3 are options. All 3 are something you may be recommended to be treated with. And the subtle differences we see in the side effect profiles of these, a lot of them have to do with what we know from the older drug, ibrutinib, and what we're starting to see with the newer drugs as we move along. So again, this just gives a more clear description of the response to Zanubrutinib. And if we look at the most common adverse events, meaning side effects, we see diarrhea, bruising, constipation, upper respiratory infections, fatigue, shortness of breath, or swelling. This one also causes more what we call neutropenia, meaning your neutrophil count is lower with Zanubrutinib than we do see with ibrutinib or acalabrutinib. And very early on, very lower rates of bleeding, irregular heart rhythms, high blood pressure, or infections. But again, the very same thing with acalabrutinib, we likely will see higher incidence of these numbers as time moves on. If not, this may distinguish Zanubrutinib from the other 2, but as of right now, it's probably too early to make a clear determination. So just to summarize, the BTK inhibitors are second-line treatment for mantle cell lymphoma. The efficacy is similar among these agents, but the second-generation drugs to some degree are thought to be better tolerated. Follow-up is short compared to ibrutinib, so we still need more time. Again, dose reductions are the main method to overcome resistance to these drugs. If you are to develop atrial fibrillation, it can be managed with a cardiologist, or you can just switch to a different BTK inhibitor or just discontinue the class as a whole. There are certain drugs you want to avoid in conjunction with BTK inhibitors. One is called amiodarone or other classes in this drug. This is not for you to remember, but if you are started on a BTK inhibitor, something you want to mention to your treating physician if you are on other medications so they can make sure that there's no drug-drug interaction.